Well, welcome back to the afternoon session of this really invigorating and inspiring meeting. The panel that will be introduced shortly is to engage us in a discussion of investing in whole person health toward an integration of physical, behavioral, and social health. Obviously, we've had important introduction to those issues throughout the course of the morning conversations. And I would ask that we both acknowledge the insights of the morning conversations and welcome this panel to the stage. And I'm now going to turn it over to Alisahah Tilson, who's the moderator. Thank you, Betsy.
Thank you all so much. Thank you for coming back after lunch, too. Sometimes sometimes you lose the folks after lunch. So thank you so much. I hope you feel like this has been such a really invigorating time together. It has been a rough couple week or two, and so it's really nice. I have found it very invigorating, so thank you all for that and for all of that you work that you do every day. I do have the incredible honor and pleasure to serve as the State Health Director and the Chief Medical Officer for the Department of Health and Human Services in service to Mandy and the Governor, and I think hopefully what you heard this morning is how amazing it is to get to be part of that team and have that leadership and be able to execute on that vision. It's just kind of a professional dream come true, and so it is a huge honor and privilege to get to have that opportunity. And there's my boss right there as I was just speaking. Yay, I see. She wasn't even in the room. I know. Anyways, I am going to tee up just a little bit, reiterate a little bit what you heard this morning, but tee up just a little bit about this North Carolina vision for whole person health. And then I'm going to turn it over to our incredible panel, Amelia Muse, who's the director of the Foundation for Health Leadership and Innovation Center of Excellence for Integrated Care, who really help us think about integrating physical health and behavioral health. Kathy Colville, who's the Director of Healthy Communities for Cone Health. And really thinking about this from a clinical workflow and from a health system perspective and integrating in with the communities, which is amazing. Alisahah Cole, who is the Chief Community Impact Officer at Atrium Health, and really going to help us think through on the community piece, especially as we think about disparities and equity and that importance of engaging our communities. And then finally, Chris Koller, there he is. He's very tall. He's often hard to hide, but he was hiding over there. Chris Koller, who will really help bring some of that national perspective for us. He's the president of the Milbank Memorial Fund and help think through some of the financing mechanisms of this, because you can have the best intentions in the world and the best design in the world, but if you can't figure out that sustainable financing piece, then you'll need that for the sustainability piece. So really excited about that and the conversation that we'll have with each other, but then also we'll open it up for the room for conversation and questions from you all and have this be interactive. So really briefly, teeing up, and again, you heard this morning, at least from the perspective of North Carolina DHS, but we are surely committed to ensuring that all North Carolinians have that opportunity for health and well-being. And so we really, through that lens, thinking about how do we buy health, not just health care. Think about how we design, how we catalyze, and how we execute a comprehensive multi-layer, multi-element, multi-year, multi-payer plan across a unified agenda for North Carolina healthcare and health system. And I think about North Carolina, it's an incredible opportunity to try to innovate in North Carolina, or to innovate in North Carolina, because if we can do it in North Carolina, it can be translated to anywhere in the country. So I think really I'm grateful to the National Academy of Medicine to think about highlighting North Carolina. Yes, we have innovative things that we're doing, but two is that again, if we do it in North Carolina, it can translate to red states, to blue states, to everywhere across the nation, and I do believe that innovation will happen at the state. I'm going to spur that national dialogue. What North Carolina brings to the table is incredible. We're really big. We're a really, really big state. We are 10 and a half hours from boundary to boundary. We're the 9th biggest state in the country. And so when you think about scaling something, we talk about scaling something, this is a big area to try to scale something. We have urban pockets, but we're very rural. And the answers in the rural communities are different than the answers in the urban communities. So how does it work for all of our communities? We have incredible diversity that's been highlighted this morning. And so how do we think about that? How do we think about our history of institutional and structural racism and that has our diversity? We have not tapped into the strength of that diversity by intentionally segregating. So how do we think about embracing that and drawing strength from our diversity and making sure that we're very culturally humble? I've learned not to say culturally competent because we'll never all be culturally competent, but culturally humble to recognize what we don't know and have this work across all of our populations and do it with our populations, not for. And we're politically purple, right? And so healthcare is divisive. But what we're finding is that health is not. And so how do we think about that health perspective and not have it be caught in the political world, but really understanding that in general, we all actually a pretty unified concept of what drives health. And we've done a fair amount of work with some partners to saying if you have $100, how would you invest? It is incredibly consistent across gender, race, political affiliation, physicians, lay people. Pretty much everybody will invest in health very, very similarly. So that's I think the advantage is that health doesn't have to be partisan, and how do we do that, drive health despite political partisanship. And we have incredible alignment across our payers, across our partners, incredible alignment and drawing from that history of North Carolina of collaboration and partnership. And then using our Medicaid program, not as the sole driver, but as that catalyst and that market mover of our other payers in our state, and being intentional about buying health with our Medicaid dollars as we're designing that. So I think there's lots of great opportunities and lots of advantages for North Carolina. Driving this. So, and what does it take? It takes a clear vision. You clearly heard that from the governor and the secretary this morning. It takes aligning across strategic plans. We're doing that with our Healthy North Carolina 2030, which we're structuring on that Robert Wood Johnson framework of health. Thinking about our opioid action plan, our early childhood action plan, but intentional strategic alignment. And then thinking about those concrete tools and infrastructure that can be deployed across populations. And this is where we think about shared infrastructure. I get more excited about infrastructure than I ever thought I would. It does infrastructure, but it's. I think we think about what did we do in the healthcare sector where we built isolated silos. We built silos, we built our own infrastructures, and then we were dependent upon interoperability to fix those silos. Oh my. Let's not do that. Let's not do that when we think about a broader view of health, thinking about the social risk, thinking about the human services. Let's not build silos that then we have to spend all of this money trying to connect. Let's think about where do we have those shared tools, those shared resources. So where do we want to collaborate? And then where do we compete and innovate on top of that? Competition, innovation is awesome, but we don't think we necessarily have to compete and innovate on every piece of that. So where do we agree that we're going to share tools? And then where do we compete upon that? And so thinking about, again, some of the shared tools that we have really been trying to make sure is available for all of North Carolina, those standardized set of screening questions. People really like their own question. And when we compared we convened our technical advisory group, there's so many screening tools out there. All the questions are pretty much the same. Come on, I actually thought it was going to be a lot harder to get those set of questions, but it took us 3 or 4 meetings, and people understood the benefit of having a shared set of questions. A, to systematically ask that question, but B, when we think about pulling in that data and the data integration and thinking about using that population level data to guide investment, people understood that the value of having shared questions. And then NC Care 360, of course, thinking about what's the shared technology platform coupled with the people that are connecting people and people. We'll be the first state to have one shared platform. And when we go to other states where their ACOs each built their own and now they're relying on interoperability, that's a bear. So the fact that we'll have one shared infrastructure, I think, will be huge. And then we can innovate on top of that. And then aligning our push to value-based payment. And using a lot of the levers that when we do go into Medicaid managed care, those levers will really be market drivers. So we're really excited about that, and I think because in North Carolina we have such a history of collaborating, I'm really excited about those shared infrastructure pieces to accelerate. And I think this will be an area where standardization will actually fuel innovation because we're not all having to create our own wheels. We can share the wheel and then innovate on top of that. So with that as a tee up, I am going to then turn it over to my esteemed colleagues to do some brief opening remarks, and then we'll have a moderated Q&A. So I'm going to go to Kathy first, right? Okay.
All right. Thank you. Appreciate that. I just want to acknowledge that this is the after lunch crowd, which is a special crowd. Thank you. This is the dug in. This is like I'm taking the whole day off. I'm going to let the emails pile up. I'm going to be here after lunch too. I appreciate that. We are together here for a reason. We are very alike people in this room. So I appreciate how aligned I felt with so much of what I heard this morning. I was telling Wailing, it's so neat to know that you're over there in a husky and thinking and doing, and we're here thinking and doing. And we're bringing a lot of dispatches to you today from what this work looks like at a local level. I've worked in safety net access and social determinants of health in Guilford, Alamance, and Rockingham counties. Almost exclusively, that's been my focus for the last 5 years of my career at Cone Health. And I wanted to just pull one particular moment of alignment from the morning from Governor Cooper's discussion of his mission for the people of North Carolina to have lives of purpose and abundance. That spoke so much to me, and I'm bringing you in these opening remarks also the words of one of the women that we've been able to work with in Greensboro, and her definition of what health is to really underscore why we're working so hard to swim upstream in so many of these ways, and how good it feels to see the system shifting so that you're getting a little bit of the current helping along the way as well. We really appreciate that. I wanted to mention that because I work at a health system, but I'm not in clinical care, I get to be a part of the downstream, midstream, and upstream work. And I'll just tell you how I conceive of that with the example from a child with asthma. So I want us to remember and honor that there are so many health systems that are doing that downstream access to care work, that when kids get sick, we're providing access to care, we're providing, hopefully, education and management along the way, but we're also providing that emergency care service and that long-time commitment that healthcare has had to that downstream work. Because things are changing, we've also started to move to the midstream. And the midstream is where we know we have a child who has asthma. We know that there's potentially triggers that are happening in the home, and we're able to send a referral through EPIC and NC Care 360 to Josie Williams and her team at Greensboro Housing Coalition. They're able to do home visits, and they're able to resolve those issues. That's in that sort of midstream space where we're matching medical conditions and putting social determinants, integrating them. And then the upstream stuff, I have another colleague here, Stephen Sills, who's the leader of our Invest Health team in Greensboro. Mary Davis from Blue Cross Blue Shield Foundation is here as well, and there's others that have really been thinking about why do we put up with kids having to live in unhealthy homes in the first place? Why aren't we thinking about affordable housing? Why aren't we thinking about tenant leadership and eviction prevention and understanding that as the work of health systems as well? So how cool is that to get to have a job where you get to work with partners internally and externally to work at all of those levels? It is amazing. I want to go back to the midstream because I think that's where I've been asked to focus my remarks today. And again, I'm just going to tell you one particular story and hope that this particular specific story will speak in some ways for the whole. I want to just mention my colleagues Jay Smith in rehab, Beth Murray in occupational therapy, and Rhonda Rumpel in care management, not here, but these three just jump up and down about this program called Aging Gracefully. And Greensboro is one of 4 sites to have done a pilot with Aging Gracefully. The purpose is to prevent injuries in the homes of older adults by providing minor housing repairs. The pilot participants in Aging Gracefully, which was a randomized trial, had fewer falls annually, improved mean scores on their ADLs, improved quality of life, and one of the biggest jumps was in their PHQ scores for depression. Significant improvement as compared to controls. All right, so this is all important work, and I'm going to I'm going to bring to you the words of Madeline Reed. She's a resident of Greensboro. She was a participant in the first phase of Aging Gracefully. She got new back steps installed, and she also got some grab bars in the shower and things like that. But here's what I'm going to ask you to do about this. I'm going to ask you to do very crass and cynical work, and I'm going to ask you to assign a monetary value to what she's talking about as I read you her words. So how much would you pay for what I'm about to read to you? And how much would you pay for yourself? But then I also want to think, how much would you pay for your mom to get this? Ask you what this is worth to you. So in her words, I am now free to safely come and go from my home. Okay, so just how much is that worth to you? You're just doing this inside your head. I have a secure handrail and steps that are the right size. I have a secure floor on that little porch. Now I can get back to doing my own grocery shopping and taking out my own garbage. All right, are you adding up inside your head? But the greatest gift that it has given me is my freedom, and that means my independence. At the end of the bathroom repairs, which were a shower chair and grab bars, I went to take a shower for the first time. When I got out, I noticed that I had been in there for over 30 minutes. The reason I was in there for so long is that I was sitting on the shower chair crying. I know that sounds mushy, but what was causing me to cry was the realization that this was the first time in 10 years that I was able to shampoo and shower using both hands and not just one hand, because I was no longer grabbing for the wall. I felt safe and secure, and that has made all the difference in the world. This kind of help, what it does, it allows you then to give back. It allows you to be a productive member of the community of Greensboro. So this is Madeline's words. All right. Some of you gave up along the way on your math quiz. You very quickly got to priceless, right? Because this is about freedom, independence. Again, it's about that life of purpose and the sense that I'm giving back to my community. And who could put a price on that? But we have to. We have to try and understand. What that type of thing means financially. And I want to let you know that for patients in the initial pilot, the total spend per person for durable medical equipment, 6 occupational therapy visits, 4 RN visits, and housing repairs was a total of an average of $8,000 per person. So that's the cost of this work, but I'm imagining that the value calculation in your head was far higher than $8,000 for what we get out of that. And Madeline's story and the many like them are really the reason why, as hard as it is, that we come to work every day to do this. We want to create the system that rewards stories, that rewards systems that make stories like Madeline's happen, that rewards the kind of health care that makes Madeline feel like a productive member of the community of Greensboro, and that understands that as really the essence of healing and health. All right, I'm going to stop there. We'll get probably more into the weeds of it, but that's really the why of why we're doing it.
Great. Thank you, Kathy. That was amazing. Good afternoon, everyone. Okay, we're in the South. Call and response. Good afternoon, everyone. Thank you. I know it's the after lunch crowd, but we got to keep our energy up. So I'm extremely excited to be here with you today. As mentioned, I am with Atrium Health, based out of Charlotte, North Carolina. Atrium is one of the largest nonprofit healthcare systems, integrated healthcare systems in the country. We're the largest safety net provider in our region. We're the largest Medicaid provider in the state of North Carolina, and we are we cover a very diverse geographic framework in North Carolina, South Carolina, and now Georgia, as I think many of you are aware. So we cover everything from urban, very metropolitan areas to extremely rural communities and everything in between. And for Atrium, as we revamped our mission statement a few years ago, we really wanted to be intentional about continuing to serve every community. So our mission is to improve health, elevate hope, and advance healing for all. And I always tell people we were extremely intentional about those words. Notice we said improve health and not healthcare. And part of my responsibilities as Chief Community Impact Officer, because everyone always says, what does that mean? Is to really make sure that we are engaging with the community in regards to the things that we are doing for and out in the community. So 4 years ago, we launched a committee. I always say in true healthcare fashion, we started a committee. And it was to really look at the work we were doing in the community. Now, we were founded as the county hospital in Mecklenburg County. So that whole notion of the for all part of our mission is really embedded in our DNA. And I was selected to be the physician champion for our system. Our committees are co-led by physicians and administrators. So I was selected to be the physician champion of that work. And we said, okay, well, let's just take an inventory of the work that we're doing. And at the time, we had over 450 community initiatives that we were doing across our entire enterprise. And some might think, wow, that's a lot. But at the same time, we really had no strategy around that work. We didn't really have priorities around the different initiatives that we were doing. And some we had engaged the community on what was needed, and a lot we had not. And so we embarked upon a community health improvement study in 2016. We took an entire year to really, truly engage with our community in a lot of different settings, including settings that, quite frankly, were not very open to us coming in. And we had to be humble, and we had to come in on their terms, and really start to hear, quite frankly, some things that were hard for us to hear as the kind of large healthcare corporate entity, if you will. And so by doing that process, and again, we engaged in our urban, suburban, and rural communities, we found that there were actually 5 areas across all of those different communities that were consistently mentioned by our community members. And one of those 5 areas was around social determinants of health. And so we implemented screening for our patients. We embarked on GIS mapping. We actually worked with University of North Carolina, Chapel Hill, the Institute of Public Health, and I know there's some colleagues in here, to implement the heat map that now exists for the entire state of North Carolina. And then we overlaid some of our patient data. So those communities of need, we actually overlaid or looked at rates of diabetes, rates of heart disease, rates of obesity, unnecessary ED utilization, and readmissions. And guess what? There was a high correlation, right? Higher rates of all of those things that we looked at in those neighborhoods that had those high social challenges. And so again, I know I'm speaking to the choir here, and most of you are nodding your heads. You're not shocked by that. But you know, this is often the question I pose when I'm presenting that data, and I've shown that heat map in probably 1,000 different settings across every single community that we work in. And I always pose the question, well, how many are shocked? So if on the map, the high social needs area are dark red and dark orange. So I say, how many are shocked by where those neighborhoods are and where those communities are? And I've only had one person ever raise their hand in over, like I said, I've probably given this talk 1,000 times. That was shocking to me that one person was shocked, but then I had to have a conversation afterwards and found they just moved to that community. Okay, so you're not as familiar with some, but just think about that. We all intuitively know where these communities of need are, right? So why are they still communities of need? And I think that's the larger question that we as health proponents can really help others to start having that conversation, because it really is around systematic exclusion. there are systems in place, right, that have created inequity and disparity. And one of my favorite Edward Deming quotes is, "A system is perfectly designed to achieve the results it achieves." So if we are achieving disparity, if we are achieving inequity, if we are achieving poor health outcomes, well, there are systems in place that are creating that. And really, we have a huge opportunity to really start to re-engineer those systems, not just lead in these broken systems, right? But to truly re-engineer these systems. And so I tell you, that's our system for Atrium Health. That's what we're committed to doing, and that's part of my responsibility to lead as Chief Community Impact Officer. But I will tell you a little bit about why I have stayed with this organization for now going on 16 years, and I'll put my family medicine hat back on because I'm still a practicing doctor. So yesterday, I was seeing patients, and as a family medicine doctor, this whole notion of integrating, what we have always called in our specialty biopsychosocial care is really true to who we are as family medicine doctors. So let me just say we're really excited as a specialty because we finally feel like in value-based care we are on a rise. Thank you. But I started my day with a message in my EMR from my triage nurse to say, please give me a call. One of your patients passed away last night at home. So connected with my nurse, explained how my patient had passed away in his sleep. I immediately called his wife to check and see how she was doing. Very peaceful passing, definitely a death with dignity, and was something that we had discussed. And he had advanced care planning on file, so this was aligned with his wishes. That was immediately followed by my first afternoon patient of the day who primary language was Spanish, and fortunately I had the resources available in my office to be able to translate and have a real great dialogue with that patient. And it very quickly became evident that he had not received the best care in the emergency room that he had visited for an abscess. And I ended up having to admit him to our hospital. I will say it was not one of our emergency rooms that he received that care, but I ended up having to admit him into a direct admit into our hospital for continuous IV antibiotics. He had only been in this country for a year from Cuba. Fortunately did have his wife with him, so there was some family support, but was extremely scared. Extremely nervous, and I fortunately have 20-minute visit slots, not 15-minute, but obviously that conversation took longer than 20 minutes. So threw my schedule off, right, for the rest of the day. But one of the great things I love about our organization is that for our offices that really do serve again, I don't even use the term underserved or vulnerable anymore. I use the term systematically excluded. We have put the resources in those offices to really help support those of us who are taking care of patients on the front lines, the ability to take care of them to our best ability. So it was great to be able to have resources around me that I can take this additional time with this patient, and my other patients didn't necessarily have to sit and wait for me for an hour for me to see them. The last patient of the day that I did see, very interesting. I've had this patient for 16 years almost, and family's very engaged, 69-year-old African-American female, just starting to struggle with some early dementia. And we have embedded the screening for the North Carolina screening tool in our EMR system already. And again, we're screening our patients. So that screening had been done, and lo and behold, it was positive for food insecurity. Now, this is a family that I know. I take care of the whole family. It was a shock to me that this matriarch of the family had screened positive for food insecurity. And so that then opened up the conversation. Well, what's going on? And it was not an issue of financial resources. It wasn't an issue of family support. Really what the issue was is that she was at a point within her dementia where it was not safe for her to make her own meals. And again, that's a conversation that may not have happened if I hadn't done that screening, and that food insecurity question was positive. And so we utilize our community resource hub, and I was able to then electronically make a referral to Friendship Trays, which is our Meals on Wheels program in Mecklenburg County, for my patient to now have access to meals that were already prepared. So I say all that to say we know what can work. Especially when we really start to look at the causes of inequity. The question I pose is, are we really at a point where we are tired of the disparity and we're really ready to act?
Thank you.
Great, thank you. So now we're going to talk, shift to Amelia, thinking about that Center of Excellence of that integrated care. And then, Chris, you'll be the one who can tell us how to pay for all of this. Yeah.
Can't wait for that part. As part of our attentiveness to you all as the after lunch crowd and as the therapist on the panel, I'll ask everyone to take a big deep breath in through your nose, out through your mouth. Let go of any of that tension, those emails racking up in your brain. Bring it back, and we can focus on the work that we are setting out to do today and share today. And some of the things that have come up today that have really spoken to me are about the potential for change, but the difficulty of change and the readiness for change. And that is at the heart of the work that I do at the Foundation for Health Leadership and Innovation, Center of Excellence for Integrated Care. And I'll tell you about the foundation first, and then I'll tell you about the center. So the foundation is a nonprofit here in North Carolina that's focused on whole person healthcare, whole community health and wellness. We support innovative partnerships and leadership, and our vision is for all communities to be healthy and all people in our communities to flourish. So we are one of the partners for NC Care 360. We're also the home of Rural Ford, North Carolina, the North Carolina Oral Health Collaborative, and Health E and C, which is the program that helped organize the community health needs assessments in Eastern North Carolina. And through all of our programs and partnerships and work that our programs do, we really work on health issues in North Carolina and try to help catalyze change, put support and technical assistance and expertise in place where people need help with change. And my work is as the director of the Center of Excellence for Integrated Care, and our change area specialty is behavioral and physical health integration. And when I say that, there might be 100 different definitions of that for you all in the room. And I'll speak more a little bit later into our panel about what that means, the different models associated with that. But what we do at the center is help health systems, and that can be one clinic, one team of providers, a hospital system, a community collaborative of primary care and behavioral health practices, transform their clinical, operational, and financial worlds of their clinic to better support whole person care and to support integration of physical and behavioral health care. And we believe that that is on a continuum, behavioral health integration. Sometimes it means that a system is going to do the best coordination they possibly can between physical and behavioral health care. They're going to set up better protocols to communicate with external providers and make sure that very important information comes back to the primary care provider and the care team. And that important information from the primary care side is shared with the behavioral health provider. And we work in integrating primary behavioral health into primary care. We've worked on the past on integrating primary care into behavioral health, which is a little more difficult. Take me out for a cup of coffee, I'll tell you all about that. But it's very needed as well in behavioral health homes. And we also work on the integration of mental health and substance use treatment, integrated dual disorder treatment. Because of the way that policy and funding has happened over several decades, mental health and substance use, those worlds have kind of become siloed. And so patients were sent or interacted in the mental health system. And if they had a substance use need, once the mental health issue was resolved, then they could go into the substance use system and address that. And then maybe if that was better, they could go back to the mental health system if that all happened. But that's not very efficient and not working well. And so we're working with practices to help them be dual diagnosis enhanced, where patients with co-occurring disorders can receive the treatment they need in the same place by the same team of providers to treat both of their conditions. And then beyond all those types of integration, we also just want to support providers, healthcare in North Carolina and beyond being attentive to social drivers of health, which aligns with our foundation and the work of NC Care 360 and the initiatives in our state, as well as trauma-informed care. It's a big call that we get from our practices in the field that we need help being more trauma-informed. So we are trying to help all of these systems change. It's very hard. And I think it goes back to what Alicia and Steve Knorr said this morning, that the systems are designed to do exactly what they're doing. But I think that if we can truly work together in true collaboration, then change is possible. And then we also need to attend to organizational capacity and readiness. And so we're looking into the implementation science world to study organizational resilience. What makes some health systems take on these changes and thrive? What makes others have, one turnover of one provider and the whole integration things falls apart? We want to understand how to help these systems be healthy so that when we put on these changes, when they're already kind of living in chronic change, they can thrive and it's better for their patients. And we also want to attend to the wellness of our workforce and our providers. So those are some things that we want to highlight. My topic is behavioral health integration, but all of that is really a part of it. So we'll talk more.
Thank you. Thank
Yeah, try this one. So thank you very much, Betsy and the panel. I think my job is to place what you guys are doing in the national context, since we at the Milbank Memorial Fund work with a bunch of different states. And then also to be the money guy. Thank you very much, Betsy. I'm not a Finn boy, but I'll try to talk a little bit of numbers. And the perspective I bring to that is not only working with these other states and state health policy leaders like the great folks you have here, but also in a prior life I was the health insurance commissioner in Rhode Island, so regulated commercial health insurers and dealt with rate review and stuff like that. I will begin with what is definitely a Ward A. If you're in Hosky, story, because I was walking in Manhattan last night and my head was down because I was talking with someone on the phone, but I saw this license plate that said It Factor. And then I kind of looked up and realized it was this really fancy Rolls Royce, which you would not necessarily see around. My news to you guys is you may not feel like a Rolls Royce, but you got the It Factor. There's a lot of folks paying attention to you. And you should take that as being good, not a standard that you have to live up to, especially when you're kind of in the middle of it and you're dealing with the setbacks as you go through, and you're kind of some of the Groundhog Day around some of your political discussions. But you got a lot of mo, and people are watching you and pulling. And the other thing is they're pulling for you. So rest comfortable with that. What I want to do is maybe not comfortable, but be assured. What I want to do is actually cop something from the National Academy of Medicine to kind of put a frame around this. and then talk a little bit about the financing piece. So Dr. McGinnis referred to it earlier on. It's important to note that we are meeting in the Biotech Center, which reflects this kind of conflict that I used to remind my governor about. Governor, is healthcare an expense that you're really concerned about, or is it a revenue? Is it a job creation piece? And we got to hold that tension and sort of hold ourselves honest to say, which is it? And I think what gets people excited about North Carolina is you are trying to expand the frame and say, it's not just about economic opportunity. It is about what it can provide in terms of future opportunity for individuals if we pay attention to the factors that are driving our healthcare expenses. And so that's what gets people excited looking at North Carolina. It represents a challenge particularly for healthcare systems, and this is where I want to steal some from the National Academy of Medicine. Betsy and I had the privilege of serving on a committee that just finished up work around how do you integrate social needs care into healthcare settings. And there is, I will say, as a policy person, a little bit of hesitation when healthcare systems rush into social determinants. As a board member of mine said, well, given the wonderful job you've done with obesity, why should we handle you homelessness? And if I could sort of summarize the pitch from our committee in 2 words, it was health systems, be humble. And we actually came up with, it was a couple people on our committee came up with sort of the 5 A's of what health systems have to do as they approach this work, what Alicia was describing to Adrian. I think she gave an example of it in terms of their work. And they are sequential. First, you just have to raise awareness. And there's been a lot of awareness raising going on even today. The second is that you have to adjust your own systems to accommodate what you're becoming aware of. Think about how you do how appointments are scheduled. Do you even have face-to-face appointments? What are transportation benefits and things like that? Then you engage in the actual assistance around how do you help folks address the needs that you've become aware of. Then you get into more heavy-duty work around alignment. It's not enough just to assist, but we actually have to align our work with our partners who are providing social services or providing community services. And then the big one that, again, we are challenged to today is advocacy. Are we so moved that we are willing to work on these things? So thanks to the Academy of Medicine for sort of giving this framework for what the health systems ought to do. And then what Betsy and I worked on were we weren't smart enough to do that work. Maybe Betsy was, but I wasn't. We worked on some of the enablers of it, and I think this is why people get excited about North Carolina. The committee identified 3 enablers. Health information technology, North Carolina 360, check. Workforce, maybe we actually ought to pay for some of these services that we're doing. And then financing. And that is work both at the system level in terms of the advocacy that you're doing for Medicaid expansion, and then the work at the provider level around value-based payment. And that's kind of, I think that's sort of the if I'm supposed to be the money guy, the news I would bring, and I'm a big advocate for primary care around in our work. I really try to work to promote greater investment in primary care as a portion of our delivery system. I don't think that'll magically happen. I don't think you can just, in spite of the great work of family docs, you just can't say, we're going to give you value-based payment and primary care will automatically rise to the top. But if we're selling this, and this is the same thing with selling investments in social services, don't think that just because I put more money into primary care or I put more money into social services that everything else will magically take care of itself, particularly reducing healthcare expenses. Why are we talking about a return on investment in primary care or in social services expenses when we're not talking about a return on investment in diagnostic services or in pharmaceutical services? So we should not, those of us who are working to integrate social services into healthcare setting, to finance social services, to finance primary care, should not let ourselves get trapped into a return on investment argument that says, give us the money now and I'll reduce your ED visits tomorrow. Because when we're not holding the rest of the system to that same standard. But if we're going to make the case that there's got to be some redistribution here, it's got to be in the context of budget constraints. And I think that's the importance of value-based purchasing and alternate payment mechanisms, is that they actually encourage providers to think about under a fixed budget, where do I put my money? I'm close to a primary care-driven ACO in Rhode Island, and it's been fascinating to watch the decisions. This is one of the most successful ones in the country. It's been fascinating to watch the decisions that they get, that they've been going through in terms of when they work with a fixed budget, where do they put their money, and at what point do they get to social care needs. It wasn't the first thing that they got, but they got to it because pretty soon after they had wrung out the low-hanging fruit from pharmacy and from ED visits, they went after screening folks for social health care needs and started saying, what do I got to do to meet these needs? So I think it's really important to learn the lessons. This is part of what I was supposed to do, is not only say people are watching you, but what are the lessons from some of the other places? Think about budget constraints. There is a reason why Medicaid has lower per capita increases than Medicare or commercial. It's because Mandy and her team can't print money. They have to deal with a fixed budget constraint. That doesn't happen in commercial health insurance, and frankly, it doesn't happen as much in Medicare. And so we have to accept the reality of budget constraints if we really believe that the money that's currently spent on healthcare could be better spent on social services, put in people's pockets, given to wages, put in other places. And there are states that are doing that. Oregon's been working with per capita caps for Medicaid for 4 or 5 years. Vermont's now got them. Maryland's got an all-payer waiver for their hospitals. And we're working with a number of states around actually setting targeted rates of growth on a per capita basis across all their healthcare services, so that you just, as a colleague of mine says, oh, I can't lose weight without a scale. We don't have a scale for healthcare. It's easier just to shift the money off to somebody else. So one of the lessons that you might think about from other places is, how do I get my arms around the whole thing? Because when you do that, you actually strengthen the case for making the sorts of investments that you guys are doing. Look forward to more conversation. Thank you.
That's awesome. All right, I'm going to, on the fly, change just a little bit. So I'm going to, I think us talking about the accomplishments and what we've done and what the vision is awesome. But I think a lot of the learnings is the mess. Right? What didn't work, which is great, because I think when you're on the bleeding edge, well, actually my husband says, sometimes we're not on the cutting edge, we're on the bleeding edge, like you're so far out that anyway, so a lot of us are on the bleeding edge, which is great. And I'll say that when we were thinking about where do we deploy NC Care 360 first, Kathy came to us and said, if you want a community that you can, not necessarily fail, but you can figure out the mistakes that you can choose us, because let's get in that mess together. Let's make that mistakes together. If you want a community that you can fail in, but use us. But that's where the learning is, in the mess. If we all knew how to do this, it would have been done long ago. So I think there's great lessons in the mess. And what do we learn from that? So let's talk a little bit about that mess, and then we will then open it up to questions from the audience. So Amelia, as you think about, so there's the on-the-shelf best practice models of integrating care, what looks good in a policy paper, but you actually try to implement that in practice. Can you talk about that a little bit? What are the best practices, but then what have you learned in your work of implementing, and where's the mess that we need to think about?
Sure. I have a visual, there we go, to help us a little bit, give you something to look at. So like I said before, behavioral health integration can have lots of different definitions to all of us. And it can happen in the behavioral health world, it can happen in the specialty world, it can happen in hospitals with all kinds of different providers, but kind of the big momentum, I think, going around the country and in North Carolina is in primary care, with implementing the collaborative care model, embedding therapists into primary care so that patients can have immediate therapy services when a need is identified during a primary care appointment. And the kind of heart of these models is providers working together as a team, and not just identity as a team, but really functioning as a team. And so the mess is when we miss the team-based care part of this. And I think that there are several barriers to that. Alicia may be able to speak to some of them. It's just some of the burden placed on the primary care providers right now in the primary care system with the volume of patients, all the administrative demands. And then we're saying, hey, we're adding behavioral health integration. It's going to be so great for your patients. It's going to help you save time, because rather than spending 25 extra minutes in an appointment, the therapist can come in and deal with the psychosocial stuff, do an intervention, and you all can come up with a plan together. But the implementation of that is quite tricky. But we know that it's very needed, and that most mental health care kind of occurs in the primary care system anyways. That's where most of our psychotropic medications are prescribed. Most people, I think, with a suicide attempt also visit their primary care provider. There's a time window in there. I want to say it's maybe 30 days. I'll have to look it up to confirm it, but it's a very scary statistic that people with mental health needs are coming into primary care. We need to be screening, and we need support in place, such as a therapist, a collaborating psychiatrist, to get the needs met, not just identify the need, and then the primary care provider is not sure what the next step is. So there's a lot of mess with the implementation.
Yeah. And then having your financing pieces be bifurcated. And so one of our commitments of moving into Medicaid managed care and having that financing piece be integrated, so that we can then facilitate that integrated team at the practice level, and then have the financing flow to support that team, which was one of the big. And
there is an established ROI for the collaborative care model. It's a 6-to-1 ratio, and I think there's almost like $3,500 in savings over 48 months of care of patients being in this collaborative care model, where their mental health is being managed by a primary care provider, a behavioral health care manager, and a consulting psychiatrist, using team-based care. And about over 80 randomized clinical control trials show that this is effective. So the financial benefits are there, but putting it into a system that's already stressed is difficult.
That's great. Yeah, Kathy, with Cone Health, so much of your system now is in a value-based contract, right? An at-risk value-based contract, and so you've really thought about re-engineering those clinical flows and having that be up front. So can you talk a little bit about when you try to change clinical workflows and IT pieces, and some of the lessons learned in that piece would be great.
Yes, I appreciate that. And I was actually thinking about this yesterday, because the mess and failure was not just a topic about NC Care 360, but when we met to talk about this panel, I was like, how messy are we supposed to get?
Like really messy, as messy as you can.
Who's going to be here? And I was thinking yesterday, it's like the rolling in the mud messy version or the messy bun version, and so we're somewhere on that spectrum in talking with you all. So I do think it's helpful to know that for Cone Health, Steve Norris talked this morning about Triad Healthcare Network, and obviously that entire $263 million that they get is at risk in the ACO. But Cone Health's about over 50% of Cone Health's revenue is in either shared savings or completely at-risk contracts at this point. And we have those risk agreements with all of the commercial payers except for one. And as Steve mentioned, on the ACO side, they're in the next-gen model, which is the full risk model for that. So I think that even amidst all of the mess, that is really the huge enabling factor for us, for people at the highest levels of the organization, to be thinking about innovation and flexibility in how we provide care. And because THN was successful early on in 2014, we've had a number of years to move forward with that mindset. So even amongst the mess, there really is an opportunity to do this. Now the mess sort of looks like this. Steve Knorr and Terry Aiken, our CEO, and all those folks that are at the top level saying, yes, let's move this forward, but the work that has to be done happening at a sort of a mid-level manager level and even below, and trying to get those folks to change their systems, especially when they've got pressures of making their budgets whole, is a big place where the mess comes in, right? And that's just the administrative side of this, right? These people need to lose money so that we're not doing it over here, but it's hard for them to be able to give that up. So that's one huge piece of it, is just thinking about the budgets all together, and that just being sort of an organizational culture piece that we still have a lot of work to do. One of the areas where we see it is in our charity care access. We have been completely non-strategic with that. It feels sometimes more like an insurance denial process for charity care applications than it does about thinking, who is it that's uninsured that we really want to have care, and why aren't we going out and seeking that out and being strategic in that way? And I will tell you that right now, that work looks like taking a team of people that have been doing it one way for a long time and having deep philosophical discussions about deservingness and worthiness that they carry around with them. And we uncovered that early on we were going to have that conversation, otherwise at every step of the rest of the process it was going to come up and bite us over and over. So that's a huge piece of the mess. And the other mess I want to talk about is just the data sharing and the stuff that's in place for that. And Josie and Stephen can testify to that. And I'll just very quickly, because this is the one where I can go on and on. Early on, I said, why aren't they getting it, right? The HIPAA rules don't understand, like, that you need to share stuff with community organizations. That's not public health authority. It's not healthcare operations. It doesn't fit in a bucket. So I called this guy in Chicago who leads a group called Data Across Sectors for Health. And I said, how do I do this? And he said, your first conversation with all of them is, do we really want to do this? And that's the conversation that we have to ask ourselves over and over. For any of these innovations, the start of the messiness is an agreement that we really want to do this, because the systems aren't designed to do what we're asking them to do. And we have to answer that affirmatively before we can do the shifting.
That's great. So Alicia, in thinking about, and I hope you don't feel pigeonholed into different segments, but just drawing on some of your expertise. So that deep work that you've done with the communities and thinking about, what are those really important pieces of a community engagement, and what are those missteps with community engagement, because that piece is going to be so important when we really think about equity. And so some of those lessons learned in what to do and what not to do, especially from a big health system coming in. And I'm from Atrium, I'm here to help. How do you get it?
Well, I think that's the first thing. We have to stop doing that. And that was definitely a key learning for us. We kind of revamped our community engagement with all of the different segments of the population that we deal with, and really had to level set, kind of to Chris, your comments earlier about being humble and coming in from a place of humility. And so I think the first thing was, for us, we had to be willing to be uncomfortable. And I think we all, again, as we talk about, the inequities that exist, we're going to have those uncomfortable conversations, and we're going to have to be willing to listen, right? But it's beyond just listening. And I think all of us have heard that when you're talking about engaging with the community, you need to listen, right? Our community advocates, which we have now established in a lot of our communities, I remember one of them specifically telling me to my face, I've been focus grouped to death. Don't come back in here with another focus group. I mean, they literally said that. And we had to hear that, and we had to receive that, because in our past, we had often gone into a community or into a neighborhood with a grant-funded project, and we did the project, we launched the pilot, and then the funds ran out, right? And guess what happened? We exited, right? So when you talk about the level of mistrust that exists in many of our community segments, we have to be willing to just be uncomfortable with that, acknowledge that, listen, but then hold ourselves accountable to what people are telling us. And so that was one of the key things that we how we revamped how we engage, was around, okay, we're going to listen, but then we're going to make sure that we have an infrastructure in place that we're coming back to you and continuing to listen, continue to engage, but then also telling you what we've done with the information that you've given us or that you've asked us to do. And so again, our whole entire community health framework and strategy is built around what our community told us they want us to work on. I think the second thing, and this kind of ties into some of the being willing to be uncomfortable, I often say the message is important, but sometimes the messenger is more important. Sometimes the messenger is more important. And again, I think that's something we have to check ourselves as health systems, but even individually. It may not be the best for you to go into a black barber shop and talk about all the great things that your organization provides, because they might not even hear you based on how you look or how you come across, right? But I bet you have somebody in your organization that could maybe make that connection a little bit easier. And so can you train that person up? Can you provide those resources in a different way? Can you use another community partner to have those conversations? And so that was another thing that we really said, you know what? We're going to have different conversations around this. So we actually launched Mental Health First Aid in one of our now amazing partners, No Grease Barber School, which is a African-American training school that trains both barbers and beauticians. And so now every student that comes through that program gets trained on mental health first aid. And you know who had that conversation? It was one of my faith community nurses, African-American female, who had connected with one of the owners of the barbershop at church, right? So again, thinking about the what and the who is critically important. And then I think the third thing that we really are focusing on right now is how do we train our current workforce to have these conversations around equity, but also our future workforce. And so, we're really excited to partner with Wake Forest to bring a new medical school to Charlotte. I actually see Julie sitting over there. So, but that has been part of the conversation. How do we make sure that we're training, kind of, Amelia, to your point, we're training the future physicians in this team-based model of care, in a model of care that really focuses on eliminating disparities, focusing on equity, focusing on social care. And honestly, I think my biggest thing is, and kind of to Chris's point, how do we prevent medicalizing social determinants? Right? and to your point about being humble here, my wish for us is that we really start talking about just health. Not social health, not behavioral health, not medical health. It's all one. We are taking care of people. We're taking care of a person. We really need to quit siloing this work. And so how do we, with this new medical school that's coming, we're really being thoughtful and intentional about how do we train the new workforce to take care of people and take care of communities.
Great. So, Chris, again, I don't want to pigeonhole everybody. If you, I'm hearing from you, you don't necessarily want to be pigeonholed as the financing model person. So, I will give you luxury if you want to think about what are looking at across other states. What are some of the lessons learned in terms of financing models that maybe supported or didn't support integrated systems, or if there's something else you would prefer to speak on, I will give you that flexibility.
No, I got that because I actually want to go back to something that you said.
Okay.
You sort of threw off the word alignment and payer alignment. Let's spend a little bit of time thinking about that and not pay lip service to the idea or collaborate, not make it too cheap. Alignment is tough. And I'm talking alignment of the payers so that they're sending consistent signals so that Amelia can do her behavioral health and primary care integration. Because if you've got 4 payers paying you 12 different ways.
Don't get me started.
Yeah. yeah. So lessons from other states around alignment. smaller is better. It always helps if you don't have a whole lot of payers. So it's easy to talk about me and alignment in Rhode Island because we got like 3 or 4 payers. Pretty simple. Locally accountable commercial providers are really important because you got to be able to call up the boss person and say, come on, we need some speaks. The role of convening and leadership are both really important. So the payers are not going to want to get together. They're trying to compete. Even the local one. This is what I learned as a regulator. They just play by the rules that are set out for them. And if you want them to do something different, you got to change the rules. And that is the job of community leaders and government. So lessons from other places, government can be a very powerful convener, and there needs to be leaders. When in Rhode Island, I would call in the payers and the providers, our version of the atriums, and I make them listen to employers. I make them put up small business people who say, how long am I going to get rate increases? And when you get the other 80% in the conversation, it changes the conversation quite a bit. What are some other lessons? Start with quality measures. It's easier to get aligned on quality measures than it is to get on dollars. Dollars, it's really hard. If you're going to get into dollars, start talking about payment methods, because at least we can have a conversation in general about, well, do we want to put up some money to primary care on a per capita basis as upfront money to do this stuff, as opposed to just making them all perform and then paying them all on the back end. The level of transparency is really important. You have cultures within the organizations that says provider contracting is a source of competitive advantage, yet it's a source of mental illness for the providers. and you have a whole workforce that's trained to say, now keep in mind, we are completely closed about the details of our contract because those are competitive proprietary, except when it comes to Medicaid or Medicare, in which case it's all transparent. We can all figure out what people get paid. So the lessons are around, it's important to convene the payers because that's who the money travels through. Medicaid, if they're going to use managed care, needs to retain the authority of the contracts because it's all in the contracts and you can do whatever you want them to do. I ran a Medicaid managed care entity. My Medicaid director was my boss, and if they said jump, I said how high. Use that authority, and have someone who can convene the payers and include the self-insureds. Self-insureds are really important because often they benefit from this stuff and don't always step up. And figure out what the rules of engagement. I go back to what Reverend Largerton said this morning. He talks about community locally in Lumbee County, and you got to get together to meet every week. In Arkansas, the Medicaid medical director and the Arkansas Blue Cross and Blue Shield medical director meet every week to say how are we going to transform primary care. It's the same dynamic that he's describing. It's happening in a larger way because that's how you build common cause. And then every once in a while, if someone's disagreeing, you got to figure out your way through it. You can't let them just kind of throw up their hands and say, "Well, we couldn't get to agree," or they window dress it or whitewash it or something like that. But you need alignment, and that means pushing to get alignment on the key stuff.
That's awesome. Okay, so we have a couple minutes for questions. Yep. If you all take advantage of this incredible wealth of expertise and insight.
So I'm Sid Hutchinson. I'm a Wake County Commissioner, and Chris, I was particularly appreciated your comments about North Carolina having a net factor at the elected level when things seem to be falling apart, and this whole conversation is about Medicaid expansion. To hear that we're doing a lot of things right, and I'm particularly glad that Dr. Cohen's in the audience to be able to hear that message. Dr. Cohen said you had a tough week. So that's great. I appreciate that. Now, my question, Betsy, to you, is recognizing that we've got budget issues that we have to deal with. In your opening comments, you mentioned that people collectively agree on how healthcare dollars should be spent. I wonder if you can share a little bit more information about how the public sees their healthcare dollars should be spent.
Yeah, I'm really happy to, and I'm really happy to follow up as well. I have some really great slides and visual of this as well. This is a whole hour's worth of slides. But we, have done work in partnership with actually Rocco, who somebody alluded to, John Lumpkin alluded to. So Rebecca Oni and Rocco Perla, who we've done a lot of collaborative work, and they actually did focus groups. Sorry, not in Charlotte. Actually, they did in Charlotte, but actually talked to people, non-medical, not the people in the room, but non-medical people, and said, if you have $100, how would you invest that in health? And then look at a pie chart. And they did focus groups in Charlotte, in Asheville, in Raleigh, again, across race, across gender, across political affiliation, and they also, in partnership with the Medical Society, I saw Bob Sullivan somewhere, also with primary care physicians and specialist physicians. Incredibly consistent. If you look at the pie chart, about 25% clinical care, 25% housing, 25% food, 25% child care, utilities, transportation. Almost identical. In fact, the first two focus groups, which was in Charlotte, white Republican women, black Democratic women, almost to the percentage exactly the same, and thought, well, this has to be a mistake. So did it in all these other settings. The one place out in Asheville, white seniors, there was a little bit more of the pie chart going to medical care and our older population. And actually, even more fascinating, the physicians, less medical care. Physicians on average 20%. It was so fascinating. Even the specialists, the subspecialists, 20% clinical care. So really consistent. And it's common sense, right? It's what do you need to be healthy? And the answer is, and we say that, like, what do people need to be healthy? They need healthy food, safe housing, transportation, and a good paying job, right? That's what, and so we talk about, and that's what Mandy was saying, like, we hate the term social determinants of health. Oh my God, what is that? And if it's determined, we can't, And actually part of the focus groups was, what did that term? And somebody said, I don't know what stupid person behind a room came up with that term. Like, it's a terrible, nobody knows what it means. But it's fundamentally, if we ask people, what do you need to be healthy? We all know it. You need food, you need a house, you need transportation, you need a good paying job. We know it. We just aren't investing that way. So, and I'm happy to give you those. They're great graphics. Happy to give you those slides.
Hi. Thanks for a wonderful, wonderful, enlightening panel. I can't help but be struck. First, I have a comment, then a question. By the irony that North Carolina, which is at the very forefront and innovative, and all of these 18 bullet points seemingly, it still has this bugbear of transition Medicare. And this is, I believe it was 500,000 people that are kind of falling in the cracks there. Where would charity care come in that arena is one point. And the second point, and this goes on to the National Academy of Medicine, Victor, also, is are we looking at what's succeeding or not internationally? Just to give you an example, botanical natural products. Japan, they have something called functional foods. In Europe, it's called nutraceuticals. And in America, we call them dietary supplements. So these are just other areas we might look at.
Well, I'll hand it up. Right. So, I don't know if you hear in an earlier session or earlier part of the morning, but when we think about Medicaid expansion, right, huge lever to really dramatically improve the health and well-being economically as well as physically and behaviorally. It's just a huge lever we need to pull in North Carolina. But it's caught in the political divisiveness of health care, again, which is why thinking about moving to where a consensus, but it is a huge disconnect between the innovation of North Carolina and not moving on that incredibly important lever. So that clearly is a big issue we're discussing. Thinking about internationally, and thinking about what I'm really impressed when I think about other countries as well is this thought of, not exactly to your point, but the thought of food is medicine, right? Food is medicine, right? And it's recognized, we know it, huge amount of evidence, even evidence around medically tailored food in folks with chronic disease. There is probably the deepest evidence in that one piece of medically tailored food. But there is kind of a cultural piece too of like, well, if it's not, If it's not a drug, then you have to prove the ROI. I can even prove the ROI. I can show you the ROI over and over again, but it's food, and then it gets to some of the somebody said who's worthy and who isn't, right? Everybody's worthy to get a prescription. I mean, if they have insurance, not. Everybody's worthy if they have insurance for medicine, but if you need food, then that is an indication of a moral failing and you're lazy. And if you don't have food, it's because you're lazy and you're not worthy of. So there's a lot of things that are in there that is wrapped up, I think, in our culture and our system.
Food is step care. Japan, they live to be the oldest in the world, and they developed some of these functional foods which integrate into their step care medical approach.
Yeah, I would say just two things. One, in regards to our community members who unfortunately are uninsured. As a healthcare provider in a community clinic, I take care of those patients every day. And they are being taken care of by a lot of our healthcare systems across our state. And this is charity care. And this is, I often say this is actually a segment of the population that we are already 100% at risk for. So we really should be thinking about, from a clinical care standpoint, how do we better serve that segment of the population? At the same time, pushing for the policy, I would say the big P policy at the state level and the federal level to bring access to those community members. So I just want to say, as a provider who takes care of those patients every single day and those community members every single day, I think we are doing the best that we can with the resources that we have. But there are still things that we can be doing better, and I think again we have to be uncomfortable enough to state that. And then I think the whole notion of and quite frankly, the evidence around food as medicine is very, very clear. I think this is the one that we've done a lot of work around. Food insecurity was the first social determinant that we put a strategy around back in 2017 across our entire enterprise. But one of the key learnings that we found, and I know we're not supposed to be pigeonholed, but I do feel like I'm the health equity person up here. One of the things that we found, right, particularly here in the South, there are certain cultures where food is a part of that culture. So you're not going to just necessarily, I can't just tell my patient to stop eating fried chicken on Sundays, right, if that's a part of the Sunday dinner. And at least not initially, right? I have to be able to establish that trust. And so a lot of what we've done have actually been to work with our different segments of the population to learn more about what is their traditional food, that they eat as a part of their family, as a part of their culture, and then actually create healthier recipes. With substitutions for certain things, so instead of, using margarine or lard, quite frankly, a lot of people are still using that, using some of the butter substances or switching to olive oil, just little, minor recipe changes that you can at least start to have that conversation, and not just expect that you're going to change an entire family or a community's culture to eat healthy, especially when this is the way they have eaten for their whole entire life, right? And so I think, again, that goes back to us being humble and saying, okay, we have to listen. If this is your culture, then we need to be able to adjust and try to just figure out ways that we can maybe make some of those recipes a little bit healthier.
We're going to let...
Doc, can I fry that seaweed in lard?
Okay. Very good. I'm going to let Chris have the last note because Jessica has already held out. So
I'm going to speak to
to
the international piece. 5 lessons. Countries that spend a higher ratio, not total, a higher ratio of social to medical have better outcomes. And we've seen that in a bunch of different places, including NAM reports, Betsy Bradley's work. So the ratio of social to medical have better outcomes, not lower costs overall, just better outcomes, which is a pretty darn good thing. And then there are folks here from the Commonwealth Fund. They do a lot of international comparisons. Eric Schneider there wrote this really nice perspective piece. It was nice because it was short and I could actually remember it. 4 lessons from other places, because you've seen those charts about how they have longer life expectancy and lower healthcare costs. And they're just dealing with healthcare. They're not looking at the expanded definition. This is our traditional narrow, sorry, Alicia, definition of healthcare. The 4 lessons, they have lower administrative costs. They have a commitment to universal access. They have a preference for primary care, and they're paying attention to inequities and disparities. If you think about those 5 things, you're actually working on all of them. And the lesson isn't, oh, geez, we stink. Why can't we pull a rabbit out of our hat from someplace else? But that it takes work to do this stuff. And you're on the right path. You're working on the right things. You just got to hang in there.